Hello everyone. In this video, we will talk about acute bronchiolitis. So what is an acute bronchiolitis? It is the most common lower respiratory tract infection in infants and under children 2 years of age. It is characterized by inflammation, edema, necrosis of small bronchioles leading to airway obstruction and air trapping. Peak incidence occurs in winter and early spring months. Most common cause of this acute bronchiolitis is respiratory syncytial virus, which is the reason for 70 to 80% of the cases. So this is the RSV virus. Other causes include parainfluenza, influenza, adenovirus, metapneumovirus, and rhinovirus. Predisposing factors include prematurity, congenital heart disease, immunodeficiency, exposure to tobacco smoke, and overcrowding. Virus infects the bronchiolar epithelial cells, causing necrosis and sloughing. This leads to mucus, fibrin, and debris accumulation in the lumen, thereby narrowing the lumen. Submucosal edema causes airway narrowing and air trapping. This results in hyperinflation and atelectasis. Impaired gas exchange causes hypoxemia and hypercapnia. Necrosis of bronchiolar epithelium is common. Peribronchiolar lymphocytic infiltration, mucus plugging, and giant cell formation in case of RSV virus infection. So this will be the finding in bronchiolitis, where this will be the normal bronchiole with a wide lumen, whereas in case of affected inflamed wall due to infection, the lumen will be narrowed because of mucus plugging and air trapping inside the mucus with an inflamed wall. The clinical features include cough, wheezing, breathlessness, feeding difficulty, and apnea. There will be tachypnea, nasal flaring, retractions, prolonged expiration, and diffuse wheeze. In severe cases, there will be cyanosis, lethargy, and hypoxia, with SpO2 going less than 90%. Diagnosis is mainly clinical. Investigations confirm severity, and we should exclude pneumonia. Essential tests to be done include pulse oximetry, ABG test, chest X-ray, and hemogram. RSV antigen test can also be done, histology, as well as the X-ray finding. Here you will see fluffy perihilar fullness. In this area, you can see fluffy perihilar fullness. In the histology, you can find acute inflammatory exudate, acute inflammation part of the walls of the bronchioles at the cellular level. Pulse oximetry, if SpO2 is less than 92, it indicates hypoxemia. In ABG, there will be hypoxemia with hypercapnia in severe cases. Chest X-ray shows hyperinflation, peribronchial thickening, and patchy atelectasis. There will be mild lymphocytosis in the hemogram. What are all the differential diagnoses? It could be pneumonia, asthma, foreign body aspiration, congenital heart disease, or can also be GERD related aspirations. Management involves maintaining airway oxygenation, hydration, and supportive care mainly. If the SpO2 is less than 92%, poor feeding is there, cyanosis, apnea, or lethargy is there, it indicates for hospitalization. In the supportive management, it is mainly maintaining SpO2 to greater than 92% humidified oxygen via nasal cannula or a head box. Hydration is required if the baby is not feeding. Usually there will be 30% drop in feeding. So if there is more drop, we shall go for IV fluids with half DNS and 5% dextrose at 100 ml per kg per day. Nasal suctioning before feeds to clear any secretions, and temperature control and minimal handling is required. The pharmacological therapy includes nebulized salbutamol at 0.15 mg per kg per dose with a maximum of 2.5 milligram to continue only if effective. Then nebulized adrenaline with 0.5 ml per kg of 1:1000 dilution 6th hourly. Hypertonic saline of 3%. Then corticosteroids and antibiotics are not routinely indicated. Coming to the management algorithm, if it is mild, we can give home care and supportive feed, moderate oxygenation, nebulization, and IV fluids. In case of severe, there will be a need for ICU care, ventilation if needed. If the SpO2 is less than 85% despite oxygen therapy, and PaCO2 is greater than 70 mm Hg, or any signs of acidosis, apnea, or exhaustion. In case of ventilation, CPAP or pressure controlled ventilation. Coming to adjuvant and preventive therapy, palvisumab, that is RSV and monoclonal antibody, can be given as injection monthly, 15 mg per kg IM during the RSV season. It is not a vaccine per se, but it induces passive immunization type of immune response is elicited. Exclusive breastfeeding, smoke-free environment, hand hygiene can reduce the incidence of acute bronchiolitis in a newborn. So, most infants recover usually in 7 to 10 days. Mortality is less than 1% in healthy infants, but higher in congenital heart disease or premature. Post bronchiolitis wheeze may persist for months. Small subset develops asthma in the later life. To summarize, acute bronchiolitis is a self-limiting but can be severe also. Supportive care is the mainstay of treatment with oxygen and hydration. Avoid unnecessary antibiotics or steroids. Early recognition and prevention reduce mortality. Hope you have learned from this video for writing an essay. Thank you.